Hi, good morning, everyone, and glad to see you all again on this Meta Journal Hours. This is series 11, right? So we will have the next 1 hour and a half or so to appraise this paper. And this papers uh, is a study conducted by our colleagues, from and also Southeast Asia, lah. And as you can read from the title, you may actually first question come to your mind, why is it necessary at all to to conduct this study, isn't it? Yeah. But if you also think harder, I mean, many of us may not have family members who have to go through the first year with cancer, that kind of thing. I hope not many of us have to do that in this lifetime. But I can imagine once we have patients who are just diagnosed with a cancer, and you can immediately think there are many reactions, isn't it? Psychologically, people are in a great distress and even denial. But after they overcome that, they most of us have this health conscious lah. We want to protect life, we want to survive, we want to make ourselves better. So, beside what treatments have been given to us, I mean to the patients in the hospital, uh, you know, it is very common practice. Cancer patients are looking for other therapy, yeah, traditional therapy, complementary therapy. But to what extent? To what extent? So this study tried to find out how much out-of-pocket payments are being done by first-time diagnosed cancer patients, and whether this behavior of looking for outside hospital treatment uh, brought about detrimental effect or not. Whether it actually caused them to have financial, uh, you know, detrimental effect to the extent of, they become unable to pay for routines, if unable to buy food, that kind of thing. So when I first come across this paper, I thought, wow, great study, isn't it? And it has actually a very multi-center. Southeast Asia is a whole region. But then on further thought, then I was thinking whether is it really necessary. But on further thought lagi, then I realized that uh, this study, if you have read it, it does not seem to be, the finding doesn't seem to be very bad. These kind of situations, but at least this study informs us that these out-of-pocket payments are common practice, and what kind of patients are at risk of overspending for complementary therapy, just in order probably to stay survive or to be more comfortable from treatments and from disease. Yeah. So let's see this paper, and then at the end, let's see what we can learn from it in this region and for Malaysia, and see how good is a study before we interpret and learn anything that is practical and applicable. So I pass the time to our research officer from CRU, Miss Iman.
Thank you, Prof. Chu, for the introduction. Assalamualaikum and a very good morning, everyone. So, as introduced by Prof. Chu, so today we were going to appraise this paper. Okay, so this paper titled Out-of-Pocket Payments for Complementary Medicine Following Cancer and the Effect of Financial Outcomes in Middle-Income Countries in Southeast Asia, a prospective cohort study. So this study was published in Lancet Global Health in 2022. So this was a recent study. And as for the introduction, so as we all know, complementary therapies have been here, especially in the Southeast Asian region, for a long time because of our culture. And cancer patients also seek out for complementary therapy due to many reasons, such as to ameliorate the cancer therapy-induced side effects, to improve their general well-being and as for the next step after unsuccessful treatment of their conventional medical therapies. Okay, and existing evidence have shown that the use of complementary medicine might be associated with delays in seeking conventional medical care, and some patients may also use these complementary therapies or complementary medicine as an alternative, and this may lead to non-adherence to the recommended anti-cancer therapies and therefore can reduce their survival. And in terms of financial impact, complementary medicine might be an expensive alternative compared with conventional cancer therapy. So this may lead to serious economic hardship, particularly in resource-limited settings, where the practice of use of complementary medicine is deeply embedded in some local cultures compared with the conventional cancer therapies. And therefore, this justifies the need of the study in which that there is a need for a detailed analysis to provide insights to facilitate health policy making, including consideration for coverage of complementary medicine in social or national insurance programs. So this study was actually from my own reading. So this actually was actually intended to actually to prove to the local authorities or the policymakers that how much is complementary medicine is being used and how much people are willing to spend on these complementary therapies. And in terms of the research questions, so the research questions that this study is trying to address is out-of-pocket spending patterns on complementary medicine associated with adverse financial outcomes following cancer diagnosis. So to answer these research questions, the objective of the study is to investigate the spending patterns on complementary medicine and the association with adverse financial outcomes in the immediate year following cancer diagnosis among participants of the Asian Course in Oncology, or also known as the ACTION cohort study from 8 middle-income countries in Southeast Asia. So there would be two variables here. First is the independent variables, is the out-of-pocket spending patterns on complementary medicine, and the outcomes of this study is to investigate the adverse financial outcomes in immediate year following cancer diagnosis. So what are the countries that participated in the study? So there were 8 countries comprises of lower middle income countries and 2 upper middle income countries. So the lower middle income countries includes Cambodia, Myanmar, Laos, Vietnam, Indonesia, and Philippines, while the 2 upper middle income countries include our country, Malaysia, and also Thailand. So there were 8 countries involved in the study overall. And let's move on to the method of the study. So this study was a prospective longitudinal study. And as I have mentioned previously, this study was derived from the ACTION study. And in this study, they actually recruited patients that just newly diagnosed with cancer and involved from 47 centers located in 8 countries in Southeast Asia. So the eligibility criteria for this study, the patients must be first-time diagnosed with cancer, age 18 years and older, aware of their own cancer diagnosis, willing to participate in the follow-up interviews, and the patients must not currently participate in any clinical trials. So this is the study procedure of the study. So this is the baseline in which that during baseline, this was the data that were collected, include age, gender, marital status, highest attained education, clinical data, private health insurance status, whether they have their own insurance provided by their employer or it is their own individual subscription, baseline annual household income, employment status, experiences of economic hardship in the previous year, health-related quality of life, and also psychological distress. While on the 12 months after their cancer diagnosis, they were actually being collected data on the annual household income and also experience of economic hardship. So if you read on the methodology of the paper, they actually have one more timeline here, which is the 3rd month here. But in the paper, they did not really specify what type of data that they collected during this time point, and they also did not report the outcomes of the data collected during this time point. So that's why there were no data on this 3rd month's follow-up. But if you look at the protocol paper which they have cited, so the data that collected on the 3rd month includes, if I'm not mistaken, is the mental health status and also their household income. but the result was not reported for this time point. Okay, so in terms of the household income categories, it will further categorized into low income, middle income, and high income. So these were actually calculated based on the country's mean national income. So for example, if their household income is 70% less than their country's mean national income, so they were considered as low income categories. And if their income were between 75 to 149%, they were considered as middle income earners, and more than 150% is considered as high income household income categories. And in terms of the health related quality of life, so they were using this questionnaire, which is the European Organization for Research and Treatment of Cancer Quality of Life questionnaire, core 30. And this questionnaire was available in all national language except for Laos and Cambodia. And next, they were also assess on the psychological distress. So in this psychological distress, they were using the questionnaire of Hospital Anxiety and Depression Scale, HADS. And this HADS were translated for Indonesia, Malaysia, and Philippines and Thailand, while for other countries that were not available, the tools were locally translated by professionals using forward translation and back translation. And in terms of the clinical data that was obtained include cancer site, cancer stage, cancer therapy administration, and presence of comorbid conditions were retrieved from patients' medical records. Okay, so in terms of the out-of-pocket expenditures, so all participants were given a cost diaries at baseline to record any illness-related payments that were directly incurred, and this payment is not reimbursed by insurance over the 12-month period after the study recruitment. So what are the type of out-of-pocket expenditures that they can record in their diaries? So this includes conventional care, for example, inpatient and outpatient cancer care, or cancer therapy, or any medical aids and supplies, or non-health related costs to cancer, such as transportation to hospitals or childcare while they are receiving their cancer treatment, lodging, and also domestic help. And lastly is the complementary medicine use. So whether they have used any traditional or complementary health product or services.
Uh, Iman, if I may stop you
Yes,
for a while, do you have any idea how is the format required of the participants when they record in the diary of all these payments?
yes, no, Prof. They did not really state in the paper, even
Mm,
in the protocol paper.
yeah, okay,
Mm.
so it could be numbers and I don't know,
Yes. Yeah, it
whether
could
they
be
write
like
anything.
scribbles. Yeah,
Yeah,
I was imagining that it could just be like scribbles,
yeah, it
chonting
could be
chonting.
maybe it's just a receipt.
Mm.
I don't know, no, it is scribble, not sure whether eligible or not.
Yeah.
Yeah, isn't it? So this is the outcome, So every time we read paper that they measures the outcome, you want to pay additional attention how the outcome is being measured, and a good study would want to give extra attention and description as how that is being done. Like here, uh, I don't know because based on my experience and many of our colleague experience, I mean Asian people don't like to write. Correct me if I'm wrong. And different from westerner, they tend to read more and write diary, it's a kind of lifestyle, that kind of thing. And not so sure, if this you ask people to write, maybe write the numbers only, maybe it's okay lah, I think, acceptable. But I hope they discuss how how good how good was this cost diary being done by the study sample subjects, and how good was it found by the researcher when they try to make sense and understand and analyze it. Keep that in mind lah. Yeah.
Okay, so what are considered as complementary medicine? So we look at the definition of complementary medicine. So it is defined as a group of diverse medical and healthcare system, practices, and products that were not considered to be part of conventional medical therapy. So for example, the complementary medicine could include dietary supplements such as vitamins and herbs, or traditional healers such as acupuncture, and also other mind-body practices such as yoga and also qigong. So these are all considered as complementary medicine. So in this study, so there are two outcomes that the researchers were trying to investigate. So first is how much of the out-of-pocket spending on complementary medicine. So there were there were three types of out-of-pocket spending which can be derived from the overall out-of-pocket cost, or it can be health cost alone, which is the out-of-pocket cost of conventional and complementary care, and also how does this cost is derived from annual household income in the 12 months following cancer diagnosis. So there were three types of costs that were derived from these three factors. And then the other outcomes is the adverse financial outcomes. So in these adverse financial outcomes, they will categorize it further into three types of financial outcomes. First is financial catastrophe. So this was defined as the total out-of-pocket cancer-related cost equivalent to or exceeding 30% of patients' annual household income. Or it can also be categorized as medical impoverishment. So this is defined as the out-of-pocket cancer-related cost subtracted from the baseline annual household. So if it is below annual poverty income line, so it is considered as medical impoverishment. And then the other financial outcomes is economic hardship, in which that this is based on self-reported inability to make necessary household payments, such as for their rental, for their bills. So this is also considered as financial outcomes for the participants of the study. Okay, so in terms of the statistical
Sorry, Iman
analysis,
again.
yes, bro.
Yeah, maybe a bit of discussion on uh, reporting our income. I remember some times ago in one of workshop, many experts thought, this is a sensitive variable. And would you report your income? I mean, if a study asks you to report your income, would you be very honest and frank?
I think it depends on the objective of the study lah kot.
Yeah,
And also
I
most of
suppose.
the study could provide the range lah instead of like specific
Mm.
numbers.
I think in this study they are getting a specific number, I think. So I wonder how they collect that, isn't it?
Yes.
Like out-of-pocket spending on complementary medicine. The third one is annual household income. Maybe it's not too difficult. Just report from their pay slip. Not so sure about those who are in business. It's always sensitive. They report the full income. Otherwise, they have to report to income tax, isn't it? Revenue board, that kind of thing. So I don't know how they do. It could be a very uh special way of collecting this data. Uh, isn't it?
Yes, it
Yeah.
could be underreported also.
So is we I do not know how the researcher uh maintain the
Like,
quality of this data and how they do it. What if the
like how
paper is
they
just
validate
report?
the data.
Yeah, I mean in the first collection of data, how can they get the patients or participants to provide this data in a in a high quality manner, accurate and true. Yeah. Also, oh yeah, keep that in mind also. I don't find that in the paper. Do you?
No, no
They
prof.
just like take it as a macam tu kan. Eh,
Just a statement, but not really a detail on how they actually get the data or validate the data.
Okay.
Okay, so we move on to the statistical analysis of the study. So for categorical variables, so these were presented as these were presented as percentage and compared using chi-square test. And then for continuous variable were described as median and compared using non-parametric test, because the researchers found that most variables were not normally distributed. So they used Mann-Whitney U test for two subgroups and Kruskal-Wallis for more than two groups. And then they also collected data on baseline characteristic on household who reported making out-of-pocket payments for complementary expenditures, and these data were compared with those do not have any out-of-pocket payment for complementary expenditures via the chi-square test. And then variables with a p-value of less than 0.25 in the univariable analysis were included in the multivariable logistic regression to further assess the association between the patient characteristic and spending on complementary medicine. Okay, so as for the independent variables is the out-of-pocket spending on complementary medicine, and the dependent variables is the financial outcomes, which includes the incidence of financial catastrophe, medical impoverishment, and also economic hardship at 1 year after cancer diagnosis. So for the multivariable logistic analysis, they were adjusted for variables that were associated with both spending complementary medicine and also the adverse financial outcomes. So we will see later on what are the data that were adjusted. And in terms of further analysis, they did the subgroup analysis for economically disadvantaged household, which includes the low income status, those patients with previous economic hardship, unemployed or no private health insurance, and then based on country income group or based on the country itself and also the cancer site. And odds ratio was considered statistically significant when the 90% CIs did not include one, and the p-values below 0.05 were considered as statistically significant, and all analyses were done using SPSS version 22. So I think, Prof, this the one data that they did not also describe on how they actually collect is the previous poverty, which means the previous economic hardship, on how do they actually define it.
They don't collect. I mean, in the baseline, they don't collect that as well. Huh?
Yes.
It's economic hardship is that they can't I mean sustain their routine life, isn't it?
Mm,
Mm, I believe they have a way to judge that lah, but it's not clear on the paper as how they did that.
yes. Yes, on how they collect the data.
But they do actually define what is economic hardship. I believe they also apply the same definitions when they assess at baseline whether
Mm,
this and that uh, person has economic hardship, I suppose. But it's not clear lah on the paper.
yes. Okay, so these are the data that were adjusted in the multivariable logistic regression, includes countries, age and diagnosis, gender, ownership of private health insurance, whether they are employed, whether they have poverty at baseline, type of hospital, cancer stage at diagnosis, and radiotherapy administration, whether they have received any surgery, their health status, their social functioning status, and their baseline burden of pain, diarrhea, insomnia, anxiety status, and also depression status. So these are the data that were adjusted in the analysis model. Okay, so in terms of the missing data, the proportion of missingness for each variable is shown in the appendix. So these were the table that I obtained in the appendix, and this is the rate of the missingness of the data. So in terms of handling the missing data, multiple imputation was done for baseline household income, baseline poverty, poverty at 12 months, cancer stage, and also financial catastrophe at 12 months. But the authors did not really specify on how they actually model this multiple imputation.
They did mention they use almost like every important IV and DV in their imputation, but usually imputation also they need to describe how many, how many runs, and when you say 10 runs, then which one that you use, or is the one that pulled all the imputed data set is used, all that are actually missing from the paper. So we're not sure after
Yes,
imputed there are how many data sets were generated and which data set is being used in further
yes.
analysis lah. So it's not clear why they don't report it lah.
Okay, so we move on to the results of the study. So there were around 9,513 participants who were recruited into action. So among these patients, around 21% died, and then 17% were lost to follow up, and 7% withdrew from the study. Around 5% did not provide adequate data, and only 50%, which is around 4,750, included in the present analysis. And from these 4,700 participants, more than half, which is around 58%, were coming from the lower middle income countries, and 40% were from the upper middle income countries.
Sorry, just to refresh again, the upper middle income countries, just Malaysia and
Malaysia
Thailand.
and Thailand. Yes.
Okay.
Yes, Malaysia and Thailand. So this is the baseline characteristic of the Asian study. So this table were actually not available in the main paper, but it is in the supplemental table. So as you can see here, just going through the baseline characteristic, as you can see here, most of the participants were coming from Malaysia, which is around 26%, okay, compared with other countries. But then in terms of the lower middle income countries, most were from Vietnam. Okay. And then in terms of age, in terms of the overall participants, majority of the participants were in the 40 to 60 years old of age here, around 56%. Okay. And then in terms of gender, majority were female. And in terms of the, I just highlighted some important variables lah. Okay, in terms of the previous economic hardship, so this is actually quite similar, in which that half of them stated that they had previous economic hardship, but some of them denied. And then in terms of the poverty, majority of them stated that they did not have any poverty. Okay, and then in terms of the type of hospital, majority of the participants receive their conventional cancer therapy from the public hospital. In terms of the comorbid condition, majority of them did not have any comorbid, which is around 77%. And then in terms of the cancer side, so most of the participants, or majority of the participants, who actually had breast cancer, because I think this could also contributed by the percentage of gender distribution, as majority of the participants were female, around 70%. So we can found that most of the patients also diagnosed with breast cancer, which is around 31%. And these were followed with female reproductive cancers and also other cancers. I think, others which they did not really specify here what type of cancer. Okay, and then in terms of the cancer diagnosis, majority were on the second stage, stage 2 of cancer. Okay, and then these are all the data on the physical functioning and also the quality of life status here that they reported at baseline. Okay, so this data they actually define it as economic hardship in the past, refers to the inability to make essential household expenditures, including for mortgage, rentals, foods, utility bills, and so on. Okay, so we move on to the findings from the multivariable analysis. Okay, so multivariable analysis showed that the factors that were significantly associated with out-of-pocket spending on complementary medicine were being from Indonesia, Laos, Malaysia, Myanmar, or Thailand. Okay, and then hospital being managed in the public hospitals, and then those patients who have their own private health insurance. Okay, so these were statistically significant with out-of-pocket spending on complementary medicine, while on the other hand, those patients from Cambodia households and those who actually reported poverty at baseline were less likely to report spending on complementary medicine. Okay, so these are the two important characteristics in terms of the out-of-pocket spending. Okay, and then in terms of the median out-of-pocket expenditure on complementary medicine, so first I would like to highlight the country income group here. So as you can see, the lower income countries have lower amount spent on complementary medicine compared with those patients in upper middle income countries, in which they have higher out-of-pocket spending. Terbalik. Lower middle income countries have lower amount of spend but higher out-of-pocket spending compared to upper middle income countries. Okay.
Iman, if to
Yes.
put this into context,
Ah.
I think I read in in the paper they said they convert the local
Into,
currency
yes,
to USD, is it?
yes, correct.
And
They actually
another
convert, yes, they actually convert all local currencies to USD.
another consideration would be actually the you know the cost of the services or the cost of the complementary therapy of all that. Though even they compare like this, it seems like of course it's irrational. You got no money, then you cannot spend more. But that is that is that means they use less? It does not mean they use less, isn't it? I mean, I bought a bottle of whatever herb lah, yeah, and another persons in Vietnam or Cambodia bought the same bottle of herbs. The cost there could be lower, and he has consumed 10 bottles and paying the same price for 10 bottles, and I just got one bottle but I have paid already the same price. You
Which
get me?
means they spend more, right,
uh,
Prof?
they may spend less, but does not mean they use less.
Oh, okay.
The cost price, the market price of the product may be lower in different country, isn't it? So you
Yes,
want to bear in mind also, like the result here, as because they have to standardize it to a similar currency. I think here is the USD, and that does not mean the volume of usage, isn't it, of whatever complementary medicines the participant in the study. So just take it as amount of money they have to pay out of pocket. It does not actually imply the quantity or volume of product used. That's why
yes,
the
correct.
title is correct actually. Yeah, it says out of pocket of expenditure uh, in different country, but do not take it understood it as volume of product being used. It does not mean they spend less, they use less. It may be they spend equally much of complementary therapy, or they can even use more, but they just spend less.
Okay, so in contrast, the higher expenditures on complementary medicine were observed in upper middle income countries. Here, as you can see, the differences here. For example, like in upper middle income countries, they spend 60% of overall out of pocket costs. Okay, and then 43% on the healthcare costs, and also 6% from the total annual household income, compared with the participants in the lower middle income countries. And this data was not actually shown in the paper, but they actually reported in the paper, in which that expenditure on the traditional local medicine was most reported. Okay, and then followed by food and also nutritional supplement, which is around 29%. But this data were not really shown in the paper in terms of the table. They just reported it in the sentence form. Okay, so next I would like to highlight on the median out-of-pocket expenditure in terms of country and cancer site. So in terms of country, as we can see here, there were significant differences in spending pattern, in which that Malaysia actually spent most on the overall out-of-pocket cost. And then in terms of the complementary medicine from the healthcare cost is in Thailand, which is around 60%. And then the complementary medicine cost, which is the highest expenditure, is from Indonesia, which is around 16%. And then in terms of the cancer side, so participant with hematological malignancy, he reported the highest share of expenditures on complementary medicine compared with those with other cancers. Here, as I highlighted here.
Iman, would you want to make some interpretation because they are just different in denominator? Then we got the different proportion, highest proportion in different country. Like, isn't it? Like share of complementary medicine costs from overall out-pocket cost, and the next column is out from healthcare costs, and then from annual household income. So the difference here is the denominator. Once the denominator change, then the ranking changes also.
Yes.
Yeah. So you have to understand clearly what is overall out-of-pocket costs. So these out-of-pocket costs are the costs incurred when they are paying other than hospital therapy, isn't it?
Yes. Includes
Everything
hospital therapy, but that was not covered lah. That was not covered by the insurance.
not covered by insurance. Okay.
Yes, not subsidized.
In that, then is Malaysia highest. Then if it's out of healthcare costs, then healthcare costs here actually you exclude non-healthcare costs like traveling, hiring a maid, that kind of thing, isn't it? So after have to
Yes.
exclude all that, just on out of total healthcare costs, the share of the cost go to complementary medicine purchase, the highest is in Thailand. So much higher, 60%. Uh, these are again non-insurance, not covered by insurance. Out of pocket lah. Yeah. Insurance
Yes.
one, they already paid by insurance, right? Or paid by, if it's public hospital, then it's paid by, subsidized by government, isn't it? So all these are additional kind of money from the patients to buy complementary medicine. Yeah. So all this denominator when it change, then the rank change and the meaning also has changed. Though the numerator are the same. Numerator are the same, yeah. The amount of money uh, used to buy complementary medicine or therapy. So when the annual household income, it then would decide, let's say Indonesia being the most, it could be that their annual income is low. Yeah. Then
Yes.
because they spend this much and out of their not so much, so they become the most being proportion is highest on in terms of a complementary medicines cost out of their annual household income, that kind of thing. And healthcare costs, it could be very expensive in Thailand or least expensive in Thailand. Uh, and then if they use certain costs to buy complementary medicines, because healthcare cost is very low, so naturally then they become the highest
They spend
proportions.
more. Yes.
So have to understand that kind of thing. Otherwise, why it different? The change is actually in the denominator. Okay.
Okay, so next I would like to highlight the types of household income categories and also previous economic hardship. So compared with the higher income counterparts, so participants from low income household and those reported economic hardship in the year following cancer diagnosis will actually likely spend higher share of their health expenditures on the complementary medicine. So as you can see here on the third column, on the second last column here. So around from the low and middle income household income, so they spend from 25 to 30% of their healthcare costs compared with those in high income earners. Okay, so likewise, patients who are economically disadvantaged household also spend relatively higher share of their household income on the complementary medicine. So this could also be due to, like Prof. Chu mentioned, could be that their household income were low, so they actually spend more on the complementary medicine.
In relation to
In
their
relation to,
income, no?
yes, yes, in relation to their annual household income.
Mm.
Okay, so next we are going to see in terms of the subgroup analysis in terms of the country in groups. So this for the association in the out-of-pocket spending and financial outcomes. So as we can see here, there were three types of financial outcomes, which is the financial catastrophe, medical impoverishment, and also economic hardship. So in upper middle income countries, out-of-pocket spending on complementary medicine were associated with significantly higher risk of financial catastrophe and medical impoverishment, but not economic hardship. So economic hardship is the inability to make the daily basic necessities payment. Okay, and then in terms of the low middle income countries, however, these associations were not significant. Okay.
Financial catastrophe is defined by meaning
That
they
their
get
income were low than the poverty line.
become poor lah, become poor.
Yes. Yes,
So,
become poor.
so do you have the percentage of respondent who actually experienced that? No, it's just this is the
No,
IV of
yeah,
household spending.
yes, yes. Only the IV.
Okay, so it's like 50% higher risk of financial catastrophe lah.
Mm,
Yeah, even
yes.
if you're in Malaysia or Thailand. So people can spend so much until they have this catastrophe, so-called, no? Okay.
But strangely, it is not observed in lower middle income countries, Prof.
What is it has to compare to it, you have to look at the model. Let's see the model.
Okay, so this is when they compare it in each individual country. So as you can see here, in terms of Malaysia, so those out-of-pocket spending were actually associated with higher financial catastrophe and also medical impoverishment. And then in Myanmar is only financial catastrophe. In Philippines is only economic hardship. So actually it depends on the country and they have different financial outcomes. So in Thailand, it could lead
Hmm.
to higher financial catastrophe and medical impoverishment. And in Vietnam, is medical impoverishment and economic hardship.
Okay, I think
So
very
yeah,
good. This is a very good slide. What would you expect, you know? What we would expect is that if you have financial catastrophe, then you're likely also to lead to medical impoverishment and economic hardship because it's a graded. This outcome is kind of ordinal, isn't it? First, you
mm,
become poor. Uh, am I right?
yes,
Medical
yes, poor.
impoverishment. What's the definition again? Medical
Yes,
impoverishment is that you are
you're unable to, let's see,
that's economic hardship, right? The worst is hardship. Impoverishment, you let's see again. Or impoverishment is become poor. Catastrophe is you exceed 30% of your annual income. You spend so much than your total annual income. So if you spend more than 30% of total annual income, then it's a catastrophe. Meaning to say you kind of don't have saving all that lah. So if you spend so much until you become poor, so it's a medical impoverishment, become poor, poverty lah. Hardship is that you can't then sustain your life. Yeah, so it become like if you can, to me, it looks like an ordinary thing. First, you become spend so much catastrophe, then you still overshoot more than 30%, then likely you become poor. This is
mm,
probably a very close to each other. And if you spend even more, then you go into economic hardship, isn't it? So you go back to that slide. So by that kind of logic, we would want to we would expect to see more countries if they spend a lot on complementary medicine. So you can see here they are just Malaysia, Myanmar, and Thailand seems to have association between our pocket spending on financial catastrophe, and there are two country there and two country with medical impoverishment and two with economic hardship. Two country, yeah, each. So this is quite logical. More would experience the lesser impact. I mean, this lesser impact is a catastrophe lah. It's not the least evil of the three. Yeah, when you come to the medical impoverishment, they become poor. So you see, Malaysia proceeded to there, Thailand proceeded to there as well. Huh?
yes,
Yeah,
to the medical
and
impoverishment.
so Malaysia and Thailand like not too bad because probably they
Mm,
are upper middle income, so they will not go into economic hardship. They still got some saving, or they are not so economically challenged, I suppose. They are able to spend. Perhaps they are more educated accordingly, or they may have more, saving all that lah. In for Malaysia and Thailand, but you can see when you look at the others, the patterns become no pattern, or the observation become a bit inconsistent. Say Myanmar probably is okay. You will think they spend more, than they got catastrophe, but they don't have. Then they control themselves. Then they don't go into poverty. They don't go into hardship. But this is not the case with Philippines. They can spend how can they have economic hardship without having impoverishment or catastrophe? What could be the interpretation? Is it because if they don't spend, they don't spend? If they spend a lot. Does that mean that?
Could be lah, bro.
So
Until it affects the whole life, not
uh,
only these two.
yeah, because it usually logically you think no, if you spend, then you become catastrophe first, but getting worse, right? But in Philippines, it seems like no, they don't get financial catastrophe, they don't get medical impoverishment. Straight away, they spend everything and become economic hardship lah. Kalau itu betul macam tu, then if there's any Filipinos here, then they may actually verify whether this is true or not. And similar go to Vietnam lah. They seem to not spend a little bit. If they spend a lot until they become poverty and hardship. If we can accept that, then that seems to be the interpretation to me on this table and slide. Do you all agree? If this is true on the ground, the other thing that you want to be careful then whether what we observe here is actually happened by chance. It just no, it doesn't make sense. Let's say I'm a Filipino, then I can say this doesn't make sense. Then it's something you want to be careful with the data analysis and data set that you get from the Philippines and Vietnam. And then again, you want to open scientists, you don't hold any prejudice. First, you make sure that you analyze the data set is correct, the data set is of high quality and no errors. And if you did the analysis correctly, and this is a pattern of result comes out, yeah. If you believe your data is correct and no errors, analysis is properly done, and this is the result. This is the result. Yeah. Sometimes you like what I did just now. That's my prejudice. I think this is not logical, right? That kind of thing. That could be the way you always want to keep at the back of mind. But it's again, you want to be open. Could this be true? Yeah. So if this is true, then in Philippines, people do that. If one they get cancer, they don't care. Sudah cancer kan? Apalagi nak simpan? Spend. I want to live or I die. Maybe lah, I don't know. This looks like they spend a lot. They spend everything until they got economic hardship. Some quite similar go to Vietnam. If the data analysis and results are credible, this could be the interpretation. Yeah. Or could it be something is being inconsistent here? Yeah.
Okay, so that is in terms of the country. And then in terms of the cancer side, so you can see that those patients with hematological malignancy were actually is associated with all three financial outcomes, which is the financial catastrophe, medical impoverishment, and also economic hardship, compared with other type of cancers which were not statistically significant. Okay, and then in terms of
Is
the
that
country
sorry?
income group,
Is that
sorry,
something
sorry.
new? Is that something new? Does it mean that people with hematological cancer tend to spend on complementary medicine and therapy, not the other types of cancer? Or could it be something wrong with the samples?
From this data, yes, hematological cancer patients. This was also associated with the previous, this one, bro. This slide. Sorry.
Do you have the numbers of cancers for each of the cancer site? Are there?
This, the baseline. Oh yes, this one is the baseline. But majority were diagnosed as breast cancer lah. Kalau kita tengok dia punya sample size dekat sini.
Quite a good number,
Those,
huh?
yeah. Those with hematological cancer were only around 8%.
Okay, so perhaps that's the culture, yeah. Probably somehow they feel like complementary medicine can help hematological cancer more than the other type of cancer. Maybe.
Okay, so in terms of the country income group, so out-of-pocket spending on complementary medicine was consistently associated with increased risk of financial catastrophe and medical impoverishment among economically vulnerable households, such as the low-income groups and those reporting previous economic hardships. Okay, so those were from the low-income groups and had previous economic hardship, who actually has higher risk of financial catastrophe and medical impoverishment here. Okay, so before we move on to the discussion, Prof, do you have anything to add on the results or anything to discuss?
Maybe we can also wait for the audience here. They have anything burning in their heart they want to ask or they want to comment. Is there anyone you want to ask something or say something? Feel free to unmute and say something if you want.
Okay, so for the discussion, first, the spending patterns on complementary medicine and the associated adverse financial outcomes actually differed significantly. So it depends on the country level income, as we have seen in the result section, and household economic status. And those patients were from the economically disadvantaged household were more susceptible to adverse financial outcomes. And as we have seen, that upper middle income countries actually spend higher expenditures on complementary medicine, such as Malaysia and Thailand. So as you can see that from the upper middle income countries, like in our own country, the conventional cancer care is mostly subsidized by the governments, thus allowed the patients to spend more on their pocket money on complementary medicine. And besides that, as you can see that the strong socio-cultural belief about complementary medicine in the Southeast Asian setting could also lead to the high expenditures on complementary medicine, especially when the prognosis of the cancer was not favorable. Okay, and then in terms of the economically disadvantaged household, they actually spend significantly higher shares of their health expenditures and household income on complementary medicine. This could related to the more readily and available and accessible therapy. Okay, and then they could also provide cheaper option, especially those who were from the lower middle income countries where the conventional cancer therapy were not subsidized, and also other barriers that could lead to decreased access in conventional cancer care, such as the lodging, the transportation, or even the doctors and patient relationship. Okay, so the increased risk of financial catastrophe and impoverishment due to spending on complementary medicine following cancer, but then it could also lead to the ineffectiveness of certain complementary medicine, and this could not only lead to increased risk on their health status, but also increased risk of their financial harms that these products can bring, because it is not proven effective in terms of treating their cancer. Okay, so what are the recommendations that the authors suggest in the study? So first is to integrate complementary medicines. So they will increase evidence of several complementary medicines could be used in alleviating cancer symptoms and also side effects of the treatment. So policymakers could consider to integrate such therapies into mainstream cancer care, and this could also include the insurance package to cover these type of therapies to reduce financial impact and non-disclosure by participants, because some patients may not disclose to their doctors that they are taking these complementary therapies due to fear of getting scolded by the doctors, for example. And if this type of therapies were included in the conventional care therapies as a package, so this could improve the compliance to conventional care. And then second is the cost regulation, to introduce several payment mechanism for complementary medicine. For example, there could be some sort of reimbursement systems from third-party payers or government funding, depending on the country health financing system. And then third is the financial protection, in which that having integrated oncology service, which includes the complementary medicine, could actually protect, especially those with economically disadvantaged household, because these are the type of people that were more likely to use complementary medicine, yet could also face an increased risk of adverse financial outcomes. So these three are the
Yeah. Sorry. If the ASEAN's chairman or whoever asks you, which country do you think most needed this initiative? Which country would you recommend?
Maybe we could start with the lower income countries first.
Which one? Based on the data, which one would you recommend?
Indonesia. Let's see.
Indonesia. Why? Anyone? I'm still looking for data now.
Yes, it's like back to this slide again. But Indonesia is not it's not significant lah here.
Yes, I think you look at the right one.
Yeah.
Which country is at the highest risk, isn't it, to get into problem? And
Could
if
be,
this,
yeah. If we want to look at the economic hardship and then the lower middle income countries, then it could be Vietnam. Vietnam.
Seems to be the hardest
Yeah.
hit, huh? Vietnam.
Yeah, Vietnam. Because Myanmar, they actually spend less, so they have lower financial catastrophe risk. It's below 1 here, the CI.
Good thought.
Mm.
Any other data you want to go along with this data? How about the one with the bar chart?
Okay.
The box and whisker chart.
This one, bro.
The one, the whisker one. The box, box and whisker. I think it's a figure
This
one with
this
the.
one.
I
With the
think.
difference in spending patterns
Yes.
from countries, yeah.
So is it still Vietnam?
Mm,
Do you think it's still Vietnam? Need the priority of implementation of the recommendations,
mm,
but they spend relatively lesser compared to
yes, they spend lesser because
Indonesia.
yes, Indonesia, in terms of the healthcare cost from the overall healthcare cost is around 30%, but Thailand had it higher, which is around 60, almost 60%.
Mm. Yeah, that's true. You agree?
Could be because, yeah,
I'm
could be
asking
because
for
they are also high income countries or because of they are being subsidized. So they have like more cash to actually spend.
Mm. Do you agree? So it's either Vietnam or Indonesia.
Mm.
I perhaps agree with you. Probably first in Vietnam, then perhaps Indonesia, then Philippines. Philippines is a bit awkward, yeah, unusual. I think they spend everything and then they get into problem. If it's true, then also you want to look at that, isn't it? Why Philippines? Why Filipinos are behaving that manner? Or probably it's more. It could be also something wrong with the data. Logically, people don't do that, lah, isn't it? You spend little bit by little, isn't it? Then you
Mm.
cannot take it,
Yes.
or you're not careful. Then you overspend and become hardship. Okay, good.
Okay, so in terms of the strength and limitations of the study, so this study was the first multi-country cohort study that actually captured expenditures on complementary medicine in the immediate year after cancer diagnosis. So they have short, not like short lah, but it is not a very much long follow-up, so they can actually minimize the recall bias. And then in terms of the limitations, the authors stated that they actually have lack of details in spending and specific types of complementary medicine in the cost diaries as we have discussed before. And some patients may also not disclose their spending because of fear of disapproval by their oncology professionals. So this is related to the patient itself. Okay, so now it's time to appraise the paper. So first is, did the study address a clearly focused issue? So I think it's a yes, in which that they actually stated clearly in their research questions, and their objective also answered their research questions. And was the cohort recruited in an acceptable way? So it is yes, because they actually included all these multi-countries. And then in terms of the exposure, was the exposure accurately measured to minimize bias? So this is what we can say, that we cannot really say whether they have actually captured the exposure or not, which is the out-of-pocket spending. Like they only captured it in terms of the diaries. So we do not really know on how they actually record the expenditures. Do you have any opinions, Prof, on this, on the
Yeah, I agree
measurement
with
of
you.
exposure? Yeah.
If they you
Okay.
want to provide more details, then we can judge better. Although we want to believe they did it, and the result also seems to be quite logical for Thailand and Malaysia, but not the other country. Because of lacking of detailed description, then we may not be able to score better on this point. Yeah, right.
Okay. And then same also goes to the measurement of the outcome, in which that this is also according to the what they can find in the diary, and also self-report also in terms of the financial catastrophe or financial adverse outcomes. So we can also I also read it as cannot tell. So it's
Mm,
not yes or it is a no. So it depends on how they actually measure the outcomes, in which the
yeah.
financial adverse outcomes. Okay, so in terms of the confounders, so have the authors identified all important confounding factors? So for me, it's a yes, because they have stated all these factors that they have included in their multivariable analysis. And have they taken account of the confounding factors in the design or analysis? So it's a yes. And was the follow-up of the subjects complete enough? So it's a yes. And was the follow-up of the subjects long enough? So it's a yes. But I have one question, Prof, if you have any opinion. So let's say that the similar study conducted like this one, but they included patients, and they follow up patients like for a long term, like for 20 years. So do you
Mm.
think that the results of the study would be of any different if we were conducted the study in a longer term?
One thing is that they have to look at the cancer stage, lah. How
Oh.
prevalent is the cancer? They may not be survive so long. If what you think on let's say a longer term, maybe 3 years or 5 years, you may we may lost participants because of due to mortality. Yeah. So how about 2 years? Um, whether it make a difference, to the result. Cannot be 100% sure, but if possible, you also want to look at that. But again, if you have a longer follow-up, then you should introduce complexity and cost lah to the study. But I think it's quite a good strategy in this study. I think 1 year perhaps is cukup, sufficient. If you want to, I mean, after 1 year, most people, I mean, cancer patient would be able to adapt and to their life and living within the first year. If they want to try anything, I think they will try that in the first year. Then you won't. I mean, logically, you won't wait for second year. Then you start trying complementary therapy. Really, you want to do something about it. You are likely to do something about it in the first year. So I think I don't know. No
Sufficient.
answer to your question whether longer term will have a different result. I don't know. But as whether 1 year is good, I think it's 1 year is good enough. I mean, I suppose uh, for feasibility and efficiency, I believe 1 year is good. Yeah, it's good. Perhaps if there are more funding, if there are another reason to do it a longer term, why not?
Mm.
But I think you can also extrapolate longer follow-up. More will go into problems if they survive longer. I mean, if they have started using complementary medicines, if the longer follow-up is in the study, the more will go into financial problem lah. catastrophe or that. It's just how much, isn't it? And probably this note bring me back to your one of your last slide. I mean, the recommendation slide. If you go back to that recommendation slide, none of that recommendation is any specific to the study. If
Yes.
a country is rich and or the government is caring enough for the people, that recommendation can be done without this study. All should be done without this study at all. And I'm not so sure about the authors and investigator of this paper. I'm not sure whether they also discuss a bit. You have done on this 8 country. I think what we have just discussed, they should have discussed it. Which countries should be prioritized or which countries government should be more alerted to implement the recommendations. But again, each country have their own government. They don't care whether you do it or not. If I want to do it, I want to do it lah. But for this group of researcher, they have these unique privileges of data, of all these 8 countries. The one is hardest hit, as what we have just discussed, perhaps is Vietnam, and then second probably is Indonesia. Assuming the data's the quality is good lah, credible, no errors, no issue. So among these 8 countries, Vietnam is hardest hit, Indonesia probably second, and I don't know, crazy one is Philippines. Yeah, so that kind of thing.
Okay. And to go back to the summary of the results of the study, so expenditures on complementary medicine significantly increase risk of financial catastrophe and medical impoverishment in upper middle income countries only, which is Malaysia and Thailand. However, the risk was significantly higher for economically disadvantaged households. So it's irrespective of where they actually come from. So do you believe the results? So for me, it's a yes. And can the results be applied to the local population in which that in terms of the Malaysian population for the Malaysian country? So I think it's a yes. And do the results of the study fit with other available evidence? So I think it's a straightforward lah, in which that higher expenditures will lead to higher financial adverse outcomes. Okay. So for the conclusion, in this study, cancer-stricken households residing in upper middle income countries with universal health coverage spend highly shares of their own pocket money and health costs on complementary medicine compared with those from the lower middle income countries. And such expenditures were also significantly associated with increased incidence of financial catastrophe and medical impoverishments. So equally important is the finding that the economically disadvantaged household were disproportionately affected by the out-of-pocket spending on complementary medicine following cancer diagnosis, and which in turn puts this patient at risk of refusing or discontinuing their conventional medical cancer care. And the integration of evidence-supported complementary therapies into the mainstream cancer care along with the intervention to address use of non-evidence-based treatments might potentially alleviate this potential adverse financial impact among those patients. So I think that's all for our MGH for this week. Prof, do you have any last comments?
Yes, I think
Mm.
the third conclusion point, do you think it is based on the data in the study?
I think the last sentence is not, because it is not stated. It is not stated on how using the complementary medicine put the patient at risk of refusing or discontinuing their conventional cancer care.
Mm,
I think this is not based on the data lah.
not in this study lah.
Yes, not in the study. Their own,
Does
yeah.
the paper actually cite any other paper that showing or other study reporting among patients who use more complementary medicine tend to discontinue their conventional cancer care?
I think they did, Prof.
Did
Yeah.
so it's
Yes.
perhaps a bit distance kind of conclusion
But
not from
but
the
not
study.
sure what type of cancer and where
Mm.
the study come from lah.
Similarly,
Need to go back to the paper.
the fourth point also is extrapolation from their data lah. They think if insurance cover all that, then people may may have less catastrophe. Okay, I think I'm done also.
Okay, so for medical officers, you can actually scan the QR code on the screen to get your MMA CPD points. And for UPM staff, I think we will put the attendance link on the chat box in a bit.
Iman, are we done?
Yes, Prof.
Oh, okay. Is there any questions, Heidi? From the floor? No.
Prof. Chu.
Hi, who is that?
I'm Nash from Department of Community Health, UPM.
Hi. Yeah. Go ahead.
Yeah, Prof.
Any
Chu.
comments?
I just want to comment on the study results. I mean, I think this is me personally, though. I'm not sure whether you agree with me or not, but I think the biggest issue in this paper is the fact that the authors did not cover or at least discuss about the financial literacy among the patients they recruited for the study. Because if you look at the results, I know that some other factors might be playing when those cancer patients decided to spend extra money on their treatment, which might be desperation and all that. But what they did not account for during the analysis is, for me, financial literacy, and I think that is one big factor when it comes to spending, and not just on healthcare, but also on other stuffs. And if we look at the general, I guess, climate in Malaysia, where we tend to spend the money that we don't have. That also goes to show that we have low financial literacy. And I think this can be translated in the way we spend for healthcare. I think that's just my opinion. And if what they can do to improve this study is also to measure their financial literacy, and I guess control that in their analysis, where they can treat financial literacy variable as the confounder. I mean, that's just my opinion, though. Yeah, because I mean, when you have enough financial knowledge or financial literacy knowledge, you would not want to spend money that you don't have, even though you are desperate, because it will create it can create further damages to not just yourself but to your family members in terms of financial strain. Yeah, that's just my opinion, though.
Yeah. Okay. I kind of also, you reminded me of their objective lah. The study objective, right? If they are thinking along whether this financial literacy is something also they want to know about the participants, the cancer patients who are just diagnosed with cancer, then they have to measure this, isn't it? I think what they were more interested in this study is the if I may say, I'm not the investigator. I think their objective is to see the amount of money spent. So they kind of they don't want to care about whether they are literate about their finance, isn't it? Yeah. So if it sounds like, yeah, it sounds like the financial literacy is a big thing. If there is a thing that the study wanted to know, then they have to measure it.
Yeah.
Isn't it? So
but like I said, I mean, that is one way that they can improve their study, though. I know that the study have been published, but if anyone here wants to go and do further analysis, I think that is one characteristic that they should include in their analysis. And the fact that the response rate is quite bad in this research. It's about 50%.
50%.
Yeah. So yeah.
Good point. Yeah, good
Mhm.
point. So that's a huge to us in research. 50% is a huge loss, lah, isn't it?
Yeah, yeah.
So you want to be
Very.
careful, lah.
Yeah.
Yes, that's true. That's true.
All right. Thank you, Prof. Chu.
Thank you so much. Great. Thank you for your input. I think you have raised up, financial literacy. I'm not so sure. I'm sure there is a measure to that.
Well,
And
there's
also,
I guess one questionnaire that measure your knowledge on financial literacy, and I mean, it's not that hard to measure. At least gauge some information or some level of literacy on financing of the overall spending.
Yeah, I agree with you. That could be one construct that can be modifiable. Let's say
Yeah.
isn't it? So
Yeah.
the country, instead of just government do something about integrating complementary medicine in insurance coverage, all that. I mean, perhaps the individual citizen level, if you measure financial literacy, then they can intervene. Yeah, they measure that for the newly diagnosed cancer patients. Then they found that financial literacy is not so good. Then they can intervene. That time, isn't it? I believe that's possible. Yeah.
Yeah.
That could be also bring in some other thing to consider, lah. Yeah. I got cancer. Now you worry about my finance more or my health more, isn't it? So people may, yeah.
But
Also,
when you just focus on one thing, which is health, and not care about your financial status afterwards, that would not solve the problem too.
Exactly.
Because it will create a different kind of problem.
Perhaps it's a matter of timing, isn't it? First, you concern about my health, then about later, a few months later, then you talk to me about my finance health. Maybe, yeah. Good point, actually. Thank you, Nash. Thank you very much.
No problem, Prof. Chu.
Anyone else have any comments or questions? If it's not, I think feel free to go. Yeah, and you want to scan while the QR code here is for the physician MMA members. Thank you, everyone. Yeah. We would have the same one next month. I think we have not decided on the paper, but look out for our poster and advertisement notice. Am I right, Iman?
Yes, Prof. Okay, thank you, Prof. Chu. So for all participants, do not forget to fill up the attendance form before you leave the session. Thank you and see you again.
Thank you.